Comparison of adenoma detection rate and proximal serrated polyp detection rate and their effect on post-colonoscopy colorectal cancer mortality in screening patients. Introduction. Screening colonoscopy with subsequent polypectomy is considered the gold standard for the prevention of colorectal cancer, especially when performed under high-quality standards. Serrated polyps are colorectal cancer precursor lesions for which the World Health Organization recently released new diagnostic criteria. Thus, the current classification of serrated polyps comprises hyperplastic polyps, traditional serrated adenomas, and sessile serrated lesions. Compared with conventional adenomas, serrated polyps arise from the serrated pathway, which is associated with the activation of mitogenic pathways by means of mutations in the BRAF gene in sessile serrated lesions, and more rarely KRAS in traditional serrated adenomas. Tumors evolving through the serrated pathway account for 10% to 33% of all new CRCs. Mutations in BRAF are associated with the CPG island mutator phenotype, leading to microsatellite instability in sessile serrated lesions, progressing to sessile serrated lesions with dysplasia. These hallmarks might enable rapid growth of serrated polyps and make them prone to the development of interval-type post-colonoscopy colorectal cancer, PCCRC. However, the risk for progression of serrated polyps to PCCRC is not attributed exclusively to molecular features, but can also be attributed to high miss rates and incomplete resection, highlighting the importance of adequate performance metrics for serrated polyp management. The detection and removal of serrated polyps is often more challenging than that of adenomas, owing to smooth edges, a similar color to that of healthy colonic mucosa, and a flat appearance. Furthermore, sessile serrated lesions are located in the right colon more often than adenomas. Due to the dissimilarities with colorectal adenomas and the need for quality standards for serrated polyp detection, parameters such as the serrated polyp detection rate, the proximal serrated polyp detection rate, PSDR, and the clinically significant serrated polyp detection rate have been proposed. None of these measures has been implemented in performance recommendations, and there was only a weak recommendation for a minimum PSDR of 5% from the British Society of Gastroenterology. Ideally, a quality standard for the detection of serrated polyps would be associated with reduced risk of long-term PCCRC mortality and would be easy to calculate and report. So far, the PSDR has been well characterized. However, the PSDR suffers from high endoscopist and center variability in the literature. Most previous studies have included small sample sizes, and no study has yet established a connection between adenoma detection rate, ADR, PSDR, and an outcome measure such as PCCRC death. The aim of the current study was to investigate the correlation between ADR and PSDR, quantifying the amount of proximally detected serrated polyps. Furthermore, the authors assessed the association of ADR and PSDR at screening colonoscopy with PCCRC mortality. Background. Patients with serrated polyps are at increased risk for post-colonoscopy colorectal cancer, PCCRC. However, evidence for a dedicated serrated polyp detection rate is lacking. The aim of this study was to investigate the association of the proximal serrated polyp detection rate and adenoma detection rate with PCCRC death. Methods. This was a retrospective analysis within the Austrian Quality Assurance Program for screening colonoscopy. Spearman's rank coefficient was calculated for the assessment of association between ADR and PSDR. Whether ADR or PSDR were associated with colorectal cancer mortality was assessed by Cox proportional hazards model. Results: 229 of 729 screening colonoscopies performed by 308 endoscopists were analyzed. The adenoma detection rate as well as the PSDR were significantly associated with PCCRC death. The correlation coefficient of the ADR and PSDR calculated at every colonoscopy was 0.70, and the corresponding PSDR value for an ADR performance standard of 25% was 11.1%. At the end of the study period, 86 endoscopists, 27.9%, reached an ADR of more than 25% and a PSDR of more than 11.1%. Conclusions. The ADR as well as the PSDR were associated with PCCRC death. Striving for a high PSDR in addition to a high ADR might reduce the risk for PCCRC mortality.